Good afternoon, everyone. Thank you so much for joining us for our second READI Community Engagement webinar of the year. Today, we'll be learning about the AAMC Principles of Trustworthiness Toolkit. But before we do, let me tell you a little bit about the CTSC. The Clinical and Translational Science Collaborative of Northern Ohio is a collaborative among Case Western Reserve University and its affiliated hospital systems, Cleveland Clinic, Metro Health, University Hospitals, and the Lewis Stokes Veterans Administration Medical Center, Northeast Ohio Medical University, and the University of Toledo. We aspire to be a catalyst for high-quality clinical and translational science and transformative research to positively impact the health of those in Northern Ohio and beyond. Here's what you can expect. We'll do some introductions in the chat, and then we will hear from our esteemed presenter, and then we'll have some time for Q&A. And without further ado, I have the pleasure of introducing Dr. Philip Alberti, a population health scientist whose singular professional commitment to health equity research and action spans over 20 years. Philip Alberti is a nationally recognized thought leader about the diverse roots of health inequities and the structural solutions required to ensure all communities thrive. He has published dozens of reports, essays, and peer-reviewed articles, is a sought-after public speaker, and has served on numerous advisory boards and expert panels for diverse organizations and federal agencies. Currently, as the Association of American Medical Colleges Senior Director of Health Equity Research and Policy and the founding director of the AAMC Center for Health Justice, Dr. Alberti sparks, supports, and contributes to community-driven, multi-sector efforts that build the evidence base for programs, policies, practices, and partnerships that eliminate health inequities. Prior to joining AAMC in 2012, Dr. Alberti led research, evaluation, and planning efforts for a bureau within the NYC Department of Health and Mental Hygiene that worked to promote health equity between New York City neighborhoods. He holds a PhD in socio-medical sciences from Columbia University's Mailman School of Public Health and was a fellow in the National Institute of Mental Health Psychiatric Epidemiology Training Program. And without further ado, Dr. Alberti, the floor is yours. Thank you so much for being with us today.
I'm sorry, I just realized that I was muted. So thank you for the introduction and the opportunity to be here. Sorry that I forgot to hit the unmute. I'm thrilled to talk with you and your colleagues and community partners about the Principles of Trustworthiness Toolkit today. So again, thank you for the invitation. Just dive right in. So at the AAMC Center for Health Justice, one of our mantras is that health equity is our goal and health justice is the path. And so I'm going to spend 5 or 10 minutes kind of unpacking these two sentences and then discussing how they relate to trustworthiness as a core kind of foundation for any of this work, health equity or health justice, that we want to undertake. So for health equity being our goal, I'm going to take a big step back and say, there are really different ways that we talk about equity, particularly over these last 3, 5, 6 years when it's been such a hot topic of conversation, right? We can talk about kind of organizational equity between populations within an organization. So think about pay and promotion equity, belonging, accessibility, recruitment, et cetera. We can think about healthcare equity between patient populations, right? So keywords there might be healthcare access, telemedicine, patient engagement, social needs screening, provider cultural humility, et cetera. And then we can talk about kind of population or community level health equity outside of a health system's walls. And so we might think about, what does it mean to be an anchor institution or to conduct community health needs assessments, community engagement, of course, political determinants of health, et cetera. These are not 3 discrete kind of flavors of equity. Of course, there's a through line, right? Particularly for healthcare organizations. So a healthcare organization that is truly walking the talk on organizational EDI, of course, is going to be able to provide high quality healthcare in a way that promotes patient level healthcare equity. It's not the only thing that factors in to healthcare equity, but of course it's a significant component, right? And social science tells us that about 15 or 20% of what makes a person or a community healthy relates to medical care. So there's that connection between healthcare equity and broader community health or population health equity. We in the center, we are really laser-like focused in that third bucket, community health equity. There's work across the Association of American Medical Colleges focusing on the other two kinds of equity, but the center lives in and with our communities. And so we have adopted this definition of health equity that I'm sure you are all familiar with, right, from the CDC, that health equity is a state in which everyone has that fair and just opportunity to attain their highest level of health. And that is a crucial lodestar, but I've always kind of felt like, what does that mean? Right? What does a community actually look like or offer to its residents, its citizens, that creates that fair and just opportunity for health? And so we in the center, we've adopted this incredible framework. It's about 2 years old, kind of focused on the vital conditions for health. And this is a rethinking or a reimagining or maybe even a reframing of social determinants. So we often say things like, housing is a social determinant of health. We must address housing as a social determinant. Two things have always bothered me with that. So one, I don't think that they are particularly determinant, right? It's not a foregone conclusion that communities kind of characterized by these health harming social factors necessarily are only going to produce people and residents that are grappling with health inequities. It's not so super determinant. And also that word addressing, particularly for healthcare, right? Some healthcare organizations might think screening is addressing a social determinant, or making a referral, or committing resources, economic resources for community economic development. That word addressing is doing a really heavy lift. So for me, the vital conditions for health says this: we don't want to address housing as a social determinant. We want every community to have humane housing. Right? It's goal focused. It tells us exactly what we want. We don't want to address transportation. We want every community across this nation to be characterized by reliable transportation, meaningful work, a thriving natural world, right? Potable water, breathable air, these basic kind of fundamental building blocks of good health for everybody that we know are not equitably distributed across our communities, right? But this vital conditions framework, not only has the center adopted it, but over 50 federal agencies in service of their own development of kind of connections across federal organizations to promote community resilience, they are also framing their work around the vital conditions for health. So on the left side of that wheel, you see those kind of basic building blocks: humane housing, transportation, et cetera. On the right side of the wheel, you see kind of these urgent services that our communities need to provide in real time right now: addiction treatment, crime response, acute care for illness and injury. It's also really instructive for healthcare organizations, I think, to locate themselves, locate where you think your work in medicine and nursing, et cetera, lives across this vital conditions for health framework. And really it's here, right? There's a sliver of that urgent service of acute care for illness and injury that, of course, healthcare owns, right? There's a sliver of addiction treatment as well. But that blue kind of piece of the pie here, basic needs for health and safety, that is inclusive of high quality access to healthcare, but it also includes the drinkable water, the breathable air, the freedom from violence, right? So when it comes to health equity and that goal and the population health level, I think this is a great framework because it's goal oriented, it's asset based, it's inclusive. All communities want these things, and it helps healthcare understand that for health equity, leadership is partnership, right? There is only so much that we can do on our own before we absolutely necessarily must engage other sectors, kind of grounded in that community wisdom and belonging at the center of this wheel. So for us then, that health equity, that CDC goal, yes, it's that fair and just opportunity for health. And we'll know that we've gotten there when every community has and provides the basic vital conditions and services we all need to thrive. And this has and provides those things by default, right? This is not the opportunity that a disingenuous mayor might say, well, we built that supermarket, we built it for you, it's 5 miles down the road, there's no public transportation there, and your neighborhood has no sidewalks. But you could have accessed that supermarket for fresh fruits and vegetables, and so therefore the blame is on you, community, for not having access or availing yourself of that service. That is not what we're talking about. We are talking about those basic vital conditions, those urgent services existing without community members having to do anything, right? It is the default scenario. So this is our goal, that every community, and of course focusing on communities made marginalized, but every community has and deserves access to these basic vital conditions for health. And that's really important because for health equity, particularly the way that we in the center talk about it, it's opportunity is the outcome. We are not trying to ensure that every community has the same health, that there are no differences in health at all. We're making sure that there's no unjust differences in health between community. And that lack of justice comes from there being different kinds of opportunities across communities, different distributions of those vital conditions for health across communities. So we are about creating that fair and just opportunity for health per that CDC definition. And so what does that mean? How do we actually begin to create justice, create this opportunity? And I won't spend too much time here, but this comes from a paper that we published, kind of elucidate some of these mechanisms and figure out what healthcare's right-sized role is. But I'll just go from the bottom up and thinking about how we actually create that fair and just opportunity, create those vital conditions for our community. So in my training many, many years ago, I came up in the school of thought that there are certain social conditions that are fundamental causes of disease, right? That racism, classism, sexism, homophobia, transphobia, you name your ism and your phobia, right? These fundamental causes, right, they control access to vital resources. They embody vital resources like power, voice, beneficial social connections, information, right? They control access to that kind of opportunity, right? And because they control that access, they impact many different health outcomes through many different channels. And so when those social factors like classism and sexism and homophobia and racism find their way into our political decisions, right? When we have don't say gay laws or work requirements to access social services or voter disenfranchisement, right? When those isms and phobias dictate our policies, that next level up, that in turn creates that maldistribution of opportunity, that maldistribution of the vital conditions for health across all of our communities, right? That limits the opportunity for thriving. And that results in all of the downstream effects that you in medicine and healthcare see, right? The healthcare inequities, the health inequities, who's showing up to your ED, who has access to healthcare. All of those are kind of follow-ons from that basic fundamental cause. And so to upend, to uproot those fundamental causes, we in the center have adopted this health justice framework based on this 2015 paper by an incredible housing advocate named Emily Benfer. And so we say that we've operationalized health justice in this way. We keep one foot grounded in community wisdom and multi-sector partnership. That is our process foot. That is where we start. And we work with community members and multi-sector partners to co-develop the kinds of evidence that lead to the other foot, that research to policy action imperative. How can we identify local solutions, local and scalable solutions that can be embedded in policies at all levels, organizational, local, state, and federal, to create that health opportunity for communities across the board. And that we use both of those feet to walk towards our goal of health equity, right? All communities having those basic vital conditions in a very explicitly anti-racist, anti-discriminatory, and intersectional way. And for us to put a fine point on that, that really comes back to power. So in our work at the center, who has the power to decide which research questions we ask, which policies we interrogate, what programs we initiate, and how that is disseminated, right? So that's how we think about walking the health justice walk. And I'm going to say a little bit about each of these feet and then tie it all together why all of this is really built on the concept of trustworthiness. So I'll start with that community wisdom and community engagement. And I know I don't need to tell this audience too much about this, but we do not talk about community engagement in the typical way that it maybe happens across many institutions. That sounds kind of like, I, Philip, have a bunch of great ideas. I am going to present my great ideas to a community advisory board that convenes 4 times a year. I'm going to get some input, I'm going to get some thumbs up, and I'm going to check the box and say that we have engaged the community in our work. That is not how we try to approach it. We really want to walk the talk kind of in that green circle. This is an incredible framework from the National Academies produced about 2 years ago, co-developed by leaders across the CTSA network and their community partners and others to really talk about how we measure effective community engagement. But I think what I want to focus on now are the words in that green circle. right? Authentic community engagement is co-equal, right? It's co-created. It is equitably financed. There is shared governance. The knowledge and partnership is bi-directional or multi-directional, and you'll see that word trust, right? So for me, none of those other kind of words in the green circle can be realized unless there is trust and trustworthiness in those partnerships. So for us in the center, trustworthiness is a core commitment of authentic community engagement. So that's that one foot and how we try to think about it. On the other foot, that research to policy action, I just love sharing this framework. It's just another way to state what I already said. So we health equity scientists think about 3 generations of health equity research. We think about first generation kind of descriptive epidemiology, where are the gaps, which populations, how large are they, what are they characterized by, et cetera. Kind of second generation, more analytic epidemiology, why do these inequities exist, how are they maintained, how are they created, et cetera. And then that third generation is really the science of solution, right? This is health policy research, it's evaluation science, it's implementation science, it's how do we actually take what we've learned from those first 2 generations and embed them into kind of evidence-based, policy-based solutions. And that's where the center tries to focus. And this entire process, right, both of those feet and walking that talk, we truly believe that that process is as important as the product, right? If our product, our tools and resources, and quote unquote thought leadership and ideas that move us towards health equity, those will not be effective if they are not built in this collaborative way, in this co-equal, co-created, authentic, collaborative way. And so we at the AAMC Center for Health Justice, we want to model that process for our member medical schools, our member teaching hospitals, the VA health system, academic societies, of course. We also want to model this process for other national associations, federal agencies, grant makers, et cetera. What should those folks be expecting of health equity work? We really want to influence the understanding and the practice of this health justice for health equity framework, not just for our members, but also for health opportunity creators, whether they're policymakers or movement builders, or again, other large national organizations. And we want to build tools and resources that ease the path for this work for everyone, every health equity champion that wants to deepen their commitment to achieving that goal of health equity. And so we apply that work across 4 areas of focus for us. So the first is trustworthiness, the center data for health equity, the third, maternal health equity, and our fourth, environmental justice. And we're only going to spend time today now kind of taking a deeper dive into trustworthiness. So why trustworthiness? Why did we start our center with the principles of trustworthiness? Why is that really our foundational guiding document? So 2 of the answers I think I've already given. One, we think that trustworthiness is the cornerstone of authentic community engagement, right? How do you build co-equal partnerships without trust? We also think that trustworthiness is central to upending those fundamental causes, those isms and those phobias, right? Upending those requires a diverse movement, right? How do you build that kind of movement when there is not trustworthiness between all participants in that movement? But third and finally, even more practical. So the Center for Health Justice is part of our organization's strategic plan, which was developed in 2019. So we were building the center in 2019, 2020, pandemic hit. And early in 2020, March, February, we were beginning to think about, would there soon be clinical trials for vaccines? And that opened up a really important discourse about diversity in clinical trials and making sure that what we learned from clinical trials was applicable to all communities, again, with that focus on health equity. And in those conversations, we heard a lot from, I would say, clinical experts and scientific experts and political experts. We didn't hear any community experts, but we heard a lot of those other experts speaking on behalf of community about why or why not certain kinds of folks would choose to participate in a clinical trial or wouldn't choose to participate in a clinical trial. And the narrative that we heard from those medicine and public health and scientific experts kind of went something like this, right? Oh, if only we had a magical pamphlet, right? A magical pamphlet that had all the right local photographs and all the right local jargon that we could disseminate to our communities, they would understand that we're not like that anymore, right? We're not like Henrietta Lacks. We're not like Tuskegee. We're not like the Guatemala syphilis experiments. We're not like the Havasupai genetic research study, et cetera, et cetera, et cetera. And so we in the center, as we were building the center, thought that that was a problematic narrative, that it was ahistorical, that it ignored current, like real world in real time abuses at the hands of public health, medicine, science, et cetera. That it was patronizing, right, to put the onus in community to get over it because we are not like that anymore. And we thought that it was time, to flip the script and put the onus where it belonged, not on communities to get over kind of valid mistrust and distrust of healthcare, of medicine, of science, but on organizations with power and privilege, like academic health centers, federal agencies, local and state public health departments, that the onus is on those kinds of organizations to demonstrate that they were worthy of their community's trust. And that was a much different framing of the issue than we were hearing in 2020. So what we did, we in the center convened, and you'll hear more about this group in a little bit, this large collaborative for health equity called CHARGE, stands for Collaborative for Health Equity, Act, Research, Generate Evidence, bit of a tortured acronym, but works for us. Right now, that group boasts just under 1,500 health equity champions from across the country. About 55% or so are from an academic health center. The other 45% are their community partners, their local business partners, their public health partners, their CBO and FBO partners, et cetera. And they are always the first stop and that first kind of process foot of how we engage to develop any of our work. And so we put out a request for kind of self-applications nominations to our CHARGE community, looking for collaborators that had qualitative experience, interview experience, or just interested in exploring issues of trustworthiness vis-a-vis the COVID epidemic. So we identified 9 CHARGE members from 7 different US geographies. And then we began to develop a strategy to kind of do socially distanced, Zoom-based, if you will, community engagement. So developed all the Zoom tools and the Dropbox. We had virtual trainings. We co-developed materials to kind of ask questions, interview protocols of local community residents about trustworthiness, about vaccines and clinical trials. Had to innovate with our IRB, how to get digital copies to be okay for consent docs, et cetera. And then what happened was those 9 CHARGE collaborators over the course of a couple of months each interviewed 3 to 4 local community residents, maybe 4 to 5, from across those 7 different places to really understand and interrogate what trustworthiness would feel like and look like in those communities. And then here's where that kind of co-equal co-development comes in. That full complement of folks, so the center staff, the 9 CHARGE collaborators, and then 32 or 33 community members developed the toolkit. So we watched all 17 hours of these video interviews. We extracted some themes. We developed reflection guides and action guides and videos. And I sadly don't have the time to show you the incredible kind of 11-minute video that we spliced together from those 17 hours. If you're interested in the methodology, here's a paper that we published as a group in Frontiers just a year or so ago. And so I will go through these 10 principles that were developed. And I think you'll notice that this is not, if you know the AAMC, this is not the AAMC's voice. It's not Philip's voice or the center's voice. This really is kind of the unfiltered perspective of the community members that we worked with in developing this work. And so the first principle is all about respect and taking responsibility. Right? The community is already educated, and that's why it doesn't trust you. Right? How are we communicating? How are you communicating with community members as a dialogue between equals instead of a one-on-one lesson, right? That if only they were educated kind of lesson, right? How are we taking the time in our work to understand local knowledge, right? The past is always present, so our history and the ramifications of that history. The second principle is you are not the only experts. Right? This really speaks to, again, thinking about that vital conditions wheel, all of the kinds of necessary and insufficient expertise that is needed to build this health justice movement, right? This is about humility. So how are you partnering with community, or are you just trying to lead the community? And then how, and can you, when you're gathering input and feedback and co-developing, can you show the concrete ways that you are incorporating that local community wisdom, your multi-partner expertise into the work itself as a demonstration that you are authentically listening to others' experience and expertise. The third principle is without action, your organizational pledge is only performance. And it makes me so sad to see how true that is and has become in 2024. Right? You'll all remember all of the, the pledges, not only around, racism as a public health crisis, but all the new roles around EDI in our organizations and health equity chiefs and population health chiefs across, academic medicine, other health systems, and now that there's been this backlash, kind of the anti-equity movement, how many of those pledges really have shown and proven themselves to be hollow. And so this is about authenticity of commitment, right? How are we following up the words around health equity and health justice with true meaningful action, right? And how are we holding organizational leadership accountable for those actions and not just kind of ending it with a revision to the mission statement, a pledge, and a hollow promise. Our fourth principle is that an office of community engagement is insufficient, right? This is about commitment, right? Organizational commitment to this work, right? So have we clearly communicated via organization-wide policies and expectations around working with the community? Is that incentivized in merit, promotion, tenure conversations, right? Outside of your R01 or your service learning opportunity, whose responsibility is it to cultivate and maintain authentic community partnerships? Right? How are you demonstrating the understanding across all aspects of your organization that this work is valuable? How are you defining the value of community engagement beyond just 1.25 FTE in an office that spans an entire university or health system? The fifth principle, it doesn't start or end with a community advisory board, right? This is about the diversity of thought. Oftentimes, and I've worked with incredible community advisory boards. They are a really important tool in our toolbox of community engagement, but too often that is the only tool that is being exercised. And too often the members of those community advisory boards are kind of like the usual suspects, the folks that we always engage, the folks that we know and therefore feel comfortable with in this kind of relationship with our organizations. So this is about how are we working to engage community in different ways that extend beyond this one kind of method, and who's missing from these groups that we engage, why are they missing, and how do we go about demonstrating trustworthiness to bring new voices and new perspectives to that table. The sixth principle, diversity is more than skin deep, right? So this is acknowledging intersectionality. Right, so how does our engagement approach, your organization's engagement approach, consider that diversity is inclusive of, but extends beyond race and ethnicity, right? And have we created an approach that understands the value and importance of multiple identities and lived experiences of our community members, right? No community is a monolith. Even a community that is defined in part by race or ethnicity or background, even in that racial category, that ethnic category, there is diversity. So how do we make sure the way in which we engage appreciates, leverages, and improves our work because of that intersectionality? Number 7 might be my favorite principle. There is more than one gay bar, one bodega, and one Black church in your community, right? This is about the diversity of relationship building, right? Making sure that we are engaging all the relevant actors across our community and in multiple ways, right? How are we getting out into our community to understand, to meet with, to interact with community members where they work and live, right? We're not expecting everyone always to come to us. And again, are we routinely engaging the same people, the same organizations? Where is that diversity? And so I'll pause here just as a thought experiment. We've done a lot of polling. We do a lot of public opinion polling in our center, and we've polled on trustworthiness quite a bit. In fact, our first poll back in 2021 focused on how trustworthy different sectors of society were. So I'm going to pose to you, and I'm going to open up my chat so I can see what you type. What sector of society, so these are not individuals or people, this would be like, libraries or hospitals or schools. So what sector of society do you think is universally the most trusted? And I say universally because we've done this question 4 or 5 times, and there's one sector in your community that everybody thinks is the most trustworthy. Black, white, rich, poor, male, female, young, old, across all demographic slices, there's one sector that is always considered the most trustworthy. So in the chat, if you don't mind taking the risk, just type what you think the most trustworthy sector in our communities is. And I'll be quiet for 10 seconds. Surely someone wants to take a quick guess. The law, with some hysteria after it. Schools, churches, all good guesses. Religious institutions, so another church. So all of those are incorrect. The answer, fire departments. And I'll say a little bit about this. So, I early in my career in New York City, working in the South Bronx and in Harlem and kind of deep in Brooklyn, all of our work was community engaged, research, program development, policy work. We never partnered with fire departments, never, not once, right? So that, what do we as a sector, medicine, science, have to learn from fire departments? Interestingly, many folks said, I see school and churches and religious institutions. So you'll notice they're at the bottom of the list. Now, all sectors polled above 50%. So that means that, there's more trust than not trust. But where there was no variation in fire departments, universally endorsed, there was significant variation in who trusted and who didn't trust faith-based organizations and universities, big demographic differences. In fact, one kind of provocative way that I've framed this in the past is that in this poll, in the 2021 poll, there were more Black Americans who trusted police departments than there were members of Generation Z who trusted faith-based organizations. So again, this speaks to kind of a very nuanced understanding of trustworthiness, and that even within, our own communities, given the diversity in our communities, certain sectors are more and less trusted, and we can't always just rely on kind of our usual partners because we assume those are the most trusted. They might be for some segments of your population, but it might be the exact opposite for other important to reach sectors. So again, there's more than one bodega, one Black church, and one gay bar in your community. Principle 8 is show your work. Just be transparent, right? Are you co-developing expectations and goals with community, or are you springing them on your community, right? And are you creating an open, honest, accessible environment where community members feel safe and are able to provide feedback? And one way to do that is to be transparent with your own challenges, your own concerns, your own fears, and creating that open and safe environment. Principle 9 is intentionality. If you're going to do it, take your time, do it right. We all know this work has an incredibly long arc, right? And so therefore the thoughtfulness, the planfulness is key. So how are you continuing, right? Building trust is iterative. Demonstrating trustworthiness is a long arc, a long story. So are members of your community co-developing, involved in the continuous improvement cycle that's supporting all of the work in your community? And our final principle of trustworthiness is the project may be over, but the work is not. And I know that all of you have heard what's the phrase, the helicopter research, or the kind of jump in, jump out. This is about sustainability of these relationships, right? So what is your plan that you've developed at the outset of the work, right, to engage the community even after a specific project has ended, right? This is about bread breaking and relationship building for the purposes of bread breaking and relationship building. Those relationships do not end because your grant is over, right? Or because the class has adjourned for the semester. How are you evaluating and disseminating and developing those plans in partnership with the community to keep the knowledge, to keep that kind of bidirectionality and transparency going over time, even when the projects are over? So the principles toolkit isn't just these 10 kind of provocative statements. So you can see on the left-hand side, there's a little bit more detail about what these mean. But again, there's also the videos, there are action guides in service of co-creating together in community very specific local actions that demonstrate humility, that demonstrate transparency, understanding that those specific local actions that demonstrate humility in Boston might not be the same local actions given history and population differences as would demonstrate humility in Nashville or some other place, right? And so that really speaks to the hyper-local utility of this toolkit And, one of the things that we in associations often do is kind of create these things, and then there's really no mechanism for tracking how they're being used, where they're being used. So we have lots of anecdotal evidence of, oh, I keep the principles tacked up on my whiteboard, or we're teaching the principles in all of our introductory, health equity or SDOH classes, or, we've used these as a way to galvanize conversations when building a new partnership. That's all great, but it's all anecdotal. And so I'm super excited to report, and you'll see that the application period's crossed out, that we are actually just about to embark on a one-year journey. Our center has sought applications from communities across the country who applied in teams of 5. And the rules for the teams were you had to have someone from one of our member institutions. You had to have at least 2 community-based organizations. That's 3 of the 5. The 4th partner had to be either a local, state, tribal, county, regional government agency. And then the 5th slot was kind of an open wild card. And that core team will, with other partners in that local community, kind of implement and evaluate one principle at a time, 1 month, kind of developing what those action steps are, committing to some of those local actions, and then evaluating, well, how are partnerships improved by having these challenging conversations about intersectionality or transparency or taking responsibility? What does it mean when organizations with power and privilege actually begin, again, walking that talk on those hyper-locally defined and co-developed actions? Are partnerships strengthened as a result of this work? And is the output of those partnerships improved because of working with this toolkit? And so we have just finished the review of the many applications that we received as of January 4th. And that project will span from March of 24 for a full year to help us understand the impact of this trustworthiness toolkit. Just in my last few minutes, I also want to ping up or lift up another resource that I think is so germane to this conversation and really at this moment in time, and that's about language and kind of language's relationship to trustworthiness. So the Center for Health Justice, in collaboration with the AMA, the American Medical Association, released just about 2.5 years ago this Advancing Health Equity Guide to Language, Narratives, and Concepts. And for me, this really speaks to that first principle, right? The community is already educated. That's why it doesn't trust you. Why are we so reliant on that word educate? Why aren't we partnering with community? What message does community receive when we come at it from that power differential kind of language? And so just to dive in for 2-3 minutes on what this guide aims to do, I'm going to put an image on the screen that came from our collaborator at the AMA, Dr. Fernando de Mayo, who lives in Chicago and was driving back and forth on some highway when he noticed this billboard. And I'm going to put up the billboard, and if you have any thoughts about what narrative this message, this image is sending to you, please drop that in the chat, and then we can just talk for, again, 2 minutes about this guide, and then we'll wrap up for Q&A. So here's the image that Fernando saw. What's your reaction to this? This is from the Chicago City Health Department, approved and released this billboard. And to hear Fernando tell this story, which I have heard a couple of times, he never noticed it until the graffiti. It had been up for weeks and weeks and weeks. And it wasn't until that act of protest, that beautiful act of protest, that he noticed it. So does anyone want to share kind of what this is signaling to them? Well, I'll offer up, for me, when I first saw this, that juxtaposition of this beautiful baby, right? With the word, exactly, Black baby as an outbreak. I mean, that's terrible. Of course, yes, we understand what they're saying, right? That babies, yes, of course, can communicable diseases, of course, get your vaccine 100%. But this juxtaposition is just, it's abominable, right? It's terrible. And so that's what this guide is trying to do. It's trying to show how the messages, the words, and the images that we communicate as an academic health center, as a scientist, as a local public health department, right, can actually dredge up these deep narratives, right? These almost kind of baked in unconscious beliefs that we as a society have been consuming, right? For all of our history. And so this guide isn't about a say this, don't say that. That's not how language works. It iterates, it changes over time. But instead, it really, I think, asks us, each of us, to reflect personally on how we can make our language more respectful, more inclusive, more precise, and more action-oriented. And I think this really is one of the keys to trustworthiness, is making sure that we are taking that time to think about how our messages are crafted and potentially received, all in service and demonstrating that we are the trustworthy kind of partners that we need, right, to upend fundamental causes, to really develop authentic, co-equal partnerships in service of, working our health justice framework to achieve health equity. So that's the talk. There's all kinds of ways to get in touch with the center. Here is our main website. If you have things that you would like to disseminate, we also have a monthly newsletter. It reaches about 5,000 folks. We blast out funding opportunities, conference opportunities, new health equity resources. Of course, there's also the AAMC charge group that I mentioned is our first stop in that health justice framework and how we co-developed the principles toolkit. Again, 1,500 folks from across the country, and it didn't make it into my slide deck because it just launched today. But the newest, most recent opportunity for charge members is our call for research. So I mentioned we do a lot of polling. We developed a polling instrument with charge over the last 6 or 7 months. They told us the domains of inquiry that were most of interest to them. So it's disability justice, child health equity, healthcare access, economic equity, and then just general concepts of health equity and health justice. We did a mega oversample, so almost 7,000 respondents, representative weighted to the national census data, can kind of drill down to 2 or 3 levels of crosses and crosstabs. And now we are going to make that data set open and available to charge members for free for 2 years. So the call just opened today. Oh, thank you for posting that link. I did not come that prepared. I appreciate that. So propose, take a look at the survey, take a look at the code book, propose research questions that are focused on kind of health equity in service of, again, changing policy and practice for health opportunity. And up to five research teams will be given 2 years of free access to the data to submit abstracts, make presentations, write papers, etc. So again, this is one of the ways that we are trying to walk that collaborative, co-developed walk and talk with our charge community in our center. And then finally, here's all the different ways, QR codes, links, our social accounts that we can stay connected. So I'm glad that we have about 15 minutes for questions and conversation. So I'll stop sharing. Thanks again for the opportunity.
Thank you so much, Dr. Alberti. I'd like to pose a question to the group. Which of the, and it may be difficult to pick one because they are all, give you some food for thought. Which of the principles of trustworthiness was most striking for you? And I will put the link to the principles in the chat. Would love to see it. If you'd like to come off mute and add some context, I think that'll be helpful in getting the conversation going and seeing how we can support each other through this journey, because it will be, I don't think there's a destination here. It's a continuous investment of time, resources, and accountability for all of us. And maybe, Dr. Alberti, if you wouldn't mind sharing, which was the most striking for you? Like, well, okay.
I can, so I know the one that, and I'm sorry that my background's backwards. It wasn't earlier. I'm not sure what happened. It's disconcerting. The one that I think is always the most interesting for our members and constituents to hear is that you are not the only experts. And I think that's the most difficult maybe to overcome, kind of just given training and how valuable and important our expertise truly is. But placing that expertise, on par with or even kind of underneath that lived community wisdom and expertise is a real challenge. And so I was not surprised by that principle. I'm very glad that it was voiced in the process, but I think it usually gets a pretty big reaction from audiences, particularly those scientific, clinical, political experts that we chat with.
Thank you. Tashiana, would you like to come off mute and talk about the principle that you shared in the chat?
Sure. Hi. So the first principle stuck out to me as far as the community already being educated, and that's why they don't trust you. It was striking to me because I think it's something that in my mind I knew, but to hear like an organization actually put it to words and include it in what they consider principles and as a in the first one was enlightening to see. And I think I guess I wonder if how people have responded to that one in your experience. Was that striking to them, or um, how has the response been to that principle?
No, you're right. I mean, I think I won't lie and say that I wasn't a little bit nervous when we kind of crafted these together. And then, of course, like all organizations, there's an approval process and folks need to kick the tires on it. I was elated that we kept to the truth that we heard and learned together. And I think it is startling. I think it's for its boldness, its directness, and I think the reason that it flew, that it kind of passed muster is because I think we all recognize that that's true. Particularly in these last 5 or 6 years when we've had maybe a little bit more of an ability to have these challenging, crucial conversations in community with community as a community. I think recognizing that history is important. And I'm glad that we weren't asked to tone it down or sugarcoat it or walk it back. There definitely is a kind of oh, okay, this is a different way to talk about this work than maybe academics, government agencies typically feel comfortable with. And I think that's also part of the goal, is that these are challenging conversations. There is truth that we would rather kind of ostrich ourselves away from. And so I'm glad that struck you as an important principle.
So, David Haney, your hand is raised.
It is. Dr. Alberti, first of all, nice presentation. I thought it was excellent, and you're a very good presenter. I have two questions for you, though. One was with the community education, that kind of feeds off of what we were just talking about. But I have noticed now, as I've started, and I direct the research operations for neurology. So we have commissioned ourselves to do a lot of community outreach and really trying to do some enhanced minority recruitment for clinical trials. But they're two separate things. First, we want community outreach, then to try to approach about trial awareness. But in doing so, for some of the trials, what we've noticed is, and as you're talking about community, you cited Tuskegee and a few others as examples. And what I find is that there's a disparity within the community. I find that a lot of the older members of the community understand those very things that you were citing. And yet I have a lot of the younger community, and I want to say like maybe 30 and under, who have no idea what I'm talking about if I ever cite those things. And I was wondering if you cross that divide. And then the second one, if I could, is when we are out in the community, I often we want to send representatives who look and feel and sound like the community. And I find that difficult because there are some people on the teams who are very much engaged and very much making great representation, but they don't necessarily represent the community that we're talking to. And did you find that to be a challenge?
Two important and kind of sizable questions. So I think on the first question about generational differences and recollection, understanding of specific histories, sure, there's variability. But my next question back would be, what are the stories and the histories that under 30-year-olds do tell themselves? What are the fears, the lessons that they've learned about your institution, research in general, science in general, clinical trials in general, that might not be directly connected to an explicit historical understanding of Tuskegee or Guatemala or Henrietta Lacks, et cetera, but certainly have their roots indirectly in those stories and maybe directly to other kind of local understandings. And so I think the education flowing both ways is really important. And I think it behooves all of us in the research enterprises that we help helm to take stock of all the stories, all the histories, all the knowledge that exists in service of that bread breaking, so that relationships can be built that would then kind of open up the opportunity for clinical trial participation in a way that feels mutually beneficial to the enterprise of science, to the institution, and most importantly, to community. And so I think, that speaks to the long arc. It speaks to, making sure that you have youth. In my mind, I'm so glad you brought it up. Youth, like health justice, is a forward kind of future thinking youth agenda. The chuckleheads in DC down the street from me, they are not going to get this together. Like I am not, I am not super interested in trying to build a health equity movement that's focused on this immediacy. This is a long story, and I think we've done a lot of polling around Generation Z, and there's real opportunities there if we spend more time with younger generations. I think there is significant opportunity for political policy, scientific alignment with younger generations that might not exist with some older generations, not speaking specifically to the community that you serve. Concordance is a long-standing, important issue. And we have a systematic review under consideration right now, looking at all the evidence of racial ethnic concordance on healthcare outcomes and population health outcomes, so not clinical trial participation. And I think the end of the day story is we haven't really evaluated it at all to the extent that we should. So for me, it has heart validity and soul validity and gut validity and face validity and all that kind of stuff. The scientific resources have not been used at this point to create the internal validity. There's just a real lack of research, which I think is a hindrance to our movement for the folks that are committed to EDI and racial ethnic concordance. So that's just one little aside. But I agree and a firm advocate that making sure that our teams inside an institution reflect in some way, are able to break bread with, communicate with, resonate with our local community partners is key. But it's not the only answer. And the onus is on all of us, regardless of our identities, to do the best that we can do to build those connections, right? Yeah, I'm a cis white guy, right? I'm a gay man. I'm a first-generation high school student. I grew up pretty poor. So there are other ways in thinking about that intersectionality principle, other ways that we can build meaningful connections that are inclusive of similar race, ethnicity, but not wholly reliant on that. And as we were talking about earlier in the presentation, there's real diversity even within an ethnic group or a racial group. And so I think knowing our communities, spending that time in community to understand those nuances and find connections. Yes, of course. Again, I don't want anyone to come away from this talk without thinking that I am not deeply committed to EDI workforce diversity. It is crucial. It is not sufficient. And so again, the responsibility for making those connections does fall to all of us at the end of the day. David, I don't know if that answered your questions.
No, thank you. It was great. We're trying to work with the younger populations right now. We started doing in-services with sororities and fraternities within the university and surrounding areas. And that seems to be getting some traction, that some really good questions. And maybe, we're developing that trust, with, an implant early, as you said. Well, one of the tough things for me is metrics after that. How do we gauge whether we're, making good ground, or are we just, having meetings and talking, but really not getting any traction? And so that's the one. And I was just wondering if you could just address too that last question about just having, that sort of opposition of, should we just have people? If I'm going to go to the Latino community, do we have to have a Latino? Do we go to the Asian community? Do we have to have an Asian? That seems to be sometimes the premise of these conversations in advance, or it's kind of a given. And I'm wondering, when I looked at your slide where you saw the team members, and they were all, all different, in many ways. And I said, well, okay, that's what we need to achieve. Is that what do I need to get out in the community? Do I have to bring a team of people as opposed to maybe one or two representatives?
So the first thing I want to say is I worked with the MRCT, multi-regional clinical, out of Harvard, MRCT. We developed, I forget what the acronym stands for, multi-site clinical, anyway, to develop like a suite of metrics to actually understand from an RCT kind of clinical trial enterprise how to evaluate our EDI efforts in clinical trials. So there's a nice, beautiful kind of logic model framework, set of measurement and metrics across 7 or 8 different domains. So I will try to find that link and I'll share it with you, Jalise, to disseminate if I can't find it in the next 2 minutes. I think the question that you just posed about, what's the right mix? I think there's language concordance is key, right? So if concern about Latino populations or Spanish speaking populations or other foreign language speaking populations, there is no engagement, there is no connection without a literal understanding. So I think that issue aside, an ideal world, fantasy future state, whether it's scientific concordance or healthcare concordance, is that everyone can treat everybody, right, with the respect, the high quality, the standards, the humility, all of those words, that happens in a universal way, right? That said, I think, there is a real value for people seeing individuals that resonate with them from a cultural or an identity perspective, in positions at academic health centers, both from a workforce perspective, from an immediate connection perspective, a language perspective. I don't know, the way that you framed it almost sounded like, is the answer that we kind of segregate these efforts? No, I don't think that's the answer. I think we want institutions that are truly characterized by belonging and inclusivity, where all of us can truly learn from each other, our own cultural backgrounds, familial backgrounds, economic backgrounds, gender backgrounds, all of those things, right? To raise all of our game and being able to connect with the most diverse set of patients and community members possible. At the outset, I do believe that's really facilitated by, some of those kinds of concordance that we're talking about. But I would encourage all of us to use that almost as like a gateway to, as I said, raise all of our games to build those meaningful relationships across the work that we do.
Thank you for those great questions, David, and for your incredibly insightful thoughts and feedback, Dr. Alberti. Do we have any final thoughts, questions, or comments? I feel like we could talk about this all day. I know I want to go through each principle and just say, okay, so we're doing this. What do you think? How can we tweak it? Like, if not, I just want to give another hearty thank you to everyone who attended and participated today, and especially Dr. Alberti for all of the work that he is leading, championing, and being a part of at the AAMC Center for Health Justice and beyond. Thank you so much, Dr. Alberti.
Thank you. Really appreciate it.
So what can you do today? You can, of course, join AAMC Charge. You can schedule a READI consultation at spark.case.edu. Sign up to attend future programming and join our listserv and review CTSC DEIA resources. Thank you so much for joining us. Feel free to connect. Have a great afternoon.